Okay, first of all, thank you everyone for the welcome. Thanks to Dignity Health and CommonSpirit for having me as faculty second year in a row, and a special pleasure is being one of your program faculty this year, so thank you again. So it's very hard to moderate a discussion after you have a bunch of your sheroes who gave talks before, so okay, so I would prefer us to keep it more lively, because as the majority of you saw us, we were all like this, like from a cartoon from New Yorker, but actually we were tweeting all the time. So I would just like to prompt our audience first. Do you have some question for our amazing speakers this morning? Don't be shy. Stacy is our angel with a carefully hidden set of wings, fixing a mic for whoever wants to ask a question. Dr. Ferdinand, thank you so much.
I don't know if it's on.
Is it on?
Nope.
Besides the World's Children Day today, which is my excuse of never growing up, yesterday was International Men's Day, so I think that we should also applaud our he for she's like Dr. Ferdinand and all our speakers that are supporting us so selflessly.
Yep. Nope. That's all right. Got a big voice. All great speakers. I'm going to ask Dr. Hayes, since she was the keynote, you outlined these inequities, especially related to race, black women having shorter life expectancy, more cardiovascular disease. I saw you flash my editorial on COVID-19. The disparity was there also. What's the main driver, and what's the one thing that you would suggest as a solution for us as a society? I will tell you, being in medicine for several decades and observing these data, the Institute of Medicine report that you cited was from 2002, and perhaps the audience missed that. They may have thought you were giving some hot news.
Yeah.
So what's the main driver, and what we're going to do to reverse it?
So, and I'm not sure this is on, and for our online people, I think that'll be important. But yeah, I think it's on now. So thank you, Dr. Ferdinand. And I think one of the things that is really challenging is the lack of progress that we have made over the past 2 to 3 decades. Some progress has been made. I think I'll talk macro because you asked me for one, but I actually talking about racism as a health risk factor and then saying we're going to address racism in a structural way, which we have not until the past couple of years really said that as a society. And I think we need to continue that conversation. I think the overlap for women, for black women, is that women are not believed. Women in the society are often, when they bring complaints, they are patronized, they present with later in symptoms with cardiovascular disease and many other things. And I think that's the other part is that is an unconscious bias that even other women hold. And so the other approach has to be that we look at women and believe them. I have so many women in my practice of all race and ethnicity who have had a condition called spontaneous coronary artery dissection, which typically affects younger women. And so these women are not coming in with atypical symptoms. They are coming in saying, I have an elephant on my chest, I am sweating, I threw up, and the pain's going down my left arm. And they are shunted to not even a cardiac floor. They don't get an ECG or troponin. Or they get a troponin that is elevated and they are sent out of the hospital. And so there are just, this is not a very good answer to your question, Dr. Ferdinand, because there is not one thing that I think we can do. And if you have something you want to offer to us that's been on your mind, but I think this is one of those gnarly, big problems that each of us have to take a piece of and commit to changing it. And that may be just in your own clinical practice. But it's women in general, I mean, it's the 2 maternal cases that were presented. Women were not believed that they were sick. They were saying, I am sick.
Hi, my name's Angela, and I work with the homeless population here in Phoenix. And my question is regarding the zip code issue. Have there been any studies of CV risks on homeless women?
I'm unaware of any. I would look to perhaps some of our expertise there. The few that have been more surveyed, often because these are the folks who were most left out of any study, because many people, when they're designing a study, they want somebody they can follow up with. They need the demographics. And so sometimes the inclusion criteria for a study is having an address or a phone, right? You have to, and so again, I would look to my panelists. I'm sure there have been some, but they're not out there. And I think it's another greatly disparity population.
Yeah, I would agree with that. You have to understand that women and racially and ethnically diverse populations are just not enrolled, period, in studies. And then when you look at that, add on top of that homelessness, you're not going to get very many big studies at all.
And there's the confluence of multiple shared risk factors together. So there was a statement from the American Heart Association about the importance of housing. So and housing is an important, this all falls into the social determinants of health. So there was a whole separate statement about just the importance of housing on cardiovascular risk. So I would refer you to the AHA statement. But individuals who are homeless often also may have substance use disorders, those have cardiovascular risk. They may have mental health disorders. Those have been associated with cardiovascular risk. Because they don't have access to health care, they have the excess burden of traditional cardiovascular risk factors, poorly controlled blood pressure and undiagnosed diabetes and dyslipidemia. So we don't have good studies, but absolutely they're at high cardiovascular risk from all of these, the confluence of all these risk factors adding up all on top of each other.
We have a question from Zoom. Dr. Michos, thank you for including trans women in your discussion of women's heart health. Considering the importance of gender-affirming hormone therapy with estrogen, what should clinicians do if a trans woman patient has a life-threatening PE or heart attack? Should you stop the estrogen? Thank you.
Yeah, I think if somebody, obviously you can discuss about having them on long-term anticoagulation, but I think there would need to be some discussion about the estrogen dosing. Certainly, I would emphasize the importance of making sure everybody had an appropriate. We want to try to prevent events. VT is a little bit complicated, but in terms of like MI and ischemic stroke, making sure that everybody has a comprehensive cardiovascular risk assessment first to make sure all their risk factors are treated. And so certainly. For VTE prevention, this involves taking a comprehensive history of looking for other potential VTE risk factors, asking about family history, identifying any other flags of risk that may put them at excess risk of VTE. So if there's anything preventable that we can do in terms of avoiding immobilization and trying to avoid the DVT in the first place. But if somebody already has a life-threatening event, then I think, obviously this all involves discussion with the patient, but usually, generally, we would stop the hormone therapy in that situation. But it's whether it was something provocable, whether it's something that once we start anticoagulation therapy, but generally, I think most clinicians would stop it at that point because of the life-threatening event.
I think it's really important in these, it's a life-threatening event, but it is, for many of these individuals, a life-saving therapy. And so because of their mental health or physical health being so compromised if they go off these drugs. And some of them, if we as cardiologists say, no, you can't take it, they will find other ways to take it. And so I think having that shared decision-making, saying, you could have another fatal heart attack if you continue this, but then being supportive of them so that they get the medication under your supervision will be really important if they decide, I would rather take that risk. And I think the importance of patient self-determination, too often I've seen cardiologists tell women more with postmenopausal hormones, they can't sleep, they can't work because of such severe vasomotor. They've tried everything, and they've been saying, well, you can't take that. Well, there are ways that we can modify risk, as Dr. Michos says, and I think all of those dogmatic things that we often say to patients, they will seek care or self-medicate, and I think that having those conversations are tough ones.
Anything else from Zoom, or I may jump in a bit? Good. Okay, I would like to refocus now to our two amazing EP gurus at the end of the table, and I would like to pick your brains a bit on the position of telemedicine, both in the VA sector and the benefits of telemedicine. And so whoever is in a mood to start first,
Go
I'm not going to grill anyone.
So digital health and telemedicine is really the focus of what research that I do within the VA. The VA, it's surprising because I think people sort of look at the VA and say, the VA is sort of screwed up and there's not a lot to offer our veterans, when in fact we actually use the most cutting edge digital tools. We actually had a mandate to start telemedicine prior to even us knowing about the pandemic. So about a year prior to the pandemic, there was a mandate coming from central office telling us that we had to amp up our telemedicine because we have a huge rural population, right? Not all veterans live within, walking distance or driving distance of a VA. They often have to take a bus for like 3 to 4 hours to come for a 15-minute appointment and then hop on the bus super fast to make that 3 p.m. bus to get back to whatever place that they've come from. So telemedicine in the VA, we actually have what's called a digital divide consult. And what that is that we actually provide free telephone, free wireless internet data, and we provide tools, meaning that we've sent out iPads. So by the middle of the pandemic, we had already sent iPads out to our veterans so that they could continue their health care throughout the pandemic. We, in our EP service, we never stopped seeing patients ever. We never had any cancellations of any patients. So we were able to speak to the EP side of things and remote monitoring because our devices, our pacemakers and can, for the most part now, use Bluetooth and wireless to monitor these devices. All of our remote patients, we watched them throughout the pandemic and then did televisits to supplement that. And then cardiology consultations for EP is really rife for telemedicine because we, I hate to say, don't have to examine the patient, but they have been examined before they've been referred to the sub-specialist, right? So we just have to look at their cardia and look at their EKG strips. We can look at the caths and everything else online, and then we can provide consultation via video. So telehealth is very robust in the VA. And then the last thing I'll say before I turn it over to Dr. Tung is that we have to also be careful, though, because despite in the VA population that being robust, it is not robust, clearly, outside of the VA population, right? Because as Dr. Hayes touched on for a second, not all digital devices work for all people. I know that personally because when I go into any public restroom and I put my hand under the sink, the water doesn't turn on. Many, many times, I'll say probably 50% of the time, the water doesn't turn on. And so I'm like this, I'm like this, I'm like this. So why is that? That's because the light that's used is red LED light, and that does not penetrate people with more melanin in their skin. The other thing is there's been a couple studies now that have come out, one by Heckbert that I would suggest you read, and that is even just with ascertainment bias, with atrial fibrillation that is subclinical in people with devices. So we presume that there is what's called the AF paradox, that people who are Black have less AFib than people who are not Black, because we feel that there's this AF paradox that despite having more risk factors, they have less AF. But when you look at people purely based on data, and data is facts, when you interrogate their devices that they have, there is no difference in AF that you find between races and ethnicities. So it's important to remember it is not all equal digitally.
Thank you so much, Dr. Han. Dr. Tung?
Well, I think she stole my thunder. I should have gone first. Well, I totally agree with you. We, as electrophysiologists, the best thing we have is remote monitoring for devices. So all these are wireless nowadays, and we can follow. I did not stop for 1 minute. I think I was busier during the pandemic than I was before because, A, you could not see these patients. We had other physicians who were following devices in our organization that do not understand, as electrophysiologists do, what these devices can provide. So we had to literally enroll every patient in our clinical setting in different offices into remote monitoring. to follow them, to call them, to make them understand what remote monitoring means is so essential because, like as of yesterday, the guy that I talked about that lives off the grid, just having a remote monitor and being able to see what was happening and calling and getting them into the emergency room immediately was very helpful. I think education was very important during this pandemic with telemedicine because the population that I deal with are elderly. They do not like video conferencing. They do not want to deal with that stuff. A phone call really helped, though. And in the past, things that we could not do with phone calls, we were able to get that done. We could just follow up and see, how are you doing? That helped so much during that time, prevented ER visits, prevented bad outcomes. We were able to catch patients with worsening heart failure. So telemedicine definitely helped in this whole situation. I know it was a bad time that we have been going through, still are, but it really taught us very important things that we can change how we practice medicine. But when it comes to my patients, they refuse to do telemedicine. They want to come because I'm a hugger. So they just want to come and they say, I know it's COVID, Dr. Tung, but can I just get my monthly, 3-monthly hug? I just want to come and see you and see your smiley face. So I have to take my mask off to be able to smile at them. I have to give them a hug. But telemedicine, sometimes I have to tell them, hey, COVID is really bad. You've got to stay at home. So thank you for telemedicine that we have been able to provide ongoing patient care and not lose these patients to bad outcomes. Thank
So,
you.
Dr. Tung, actually, I have one more question for you. How do we increase the amount of the huggers? Because there is a small percentage of doctors practicing. I mean, 9%, that's really, how do we diversify that population of doctors who want to train as huggers?
Well, you know, it's sad, and I shouldn't be saying that because we are in a medical profession, but there are people who feel I'm a MD, I have the MD behind my name, and I am superior to others. I don't know, I was brought up different, I come from a different community. It's not that way. When I was transferring from Phoenix to Prescott, I have a family situation. My sister has had cardiac arrest and severe brain injury. She's a nephrologist, so I take care of her at home. For me to transition to a smaller community to get home health care for her was very difficult, so I commuted for a year. This is what touched me about this community that I work in. The patients are so lovable and so kind and so grateful for the care you provide that you're coming to do this for them that they never had before. They would leave their phone numbers at the front desk and say, please let Dr. Tung know if she travels, she drives late at night, comes back next morning. If she's stuck, if the weather's bad, there's a snowstorm, I have an extra room. She can come and stay with us. It was amazing the kind of care that they provide back for what you give to them. So it's, it's both ways. It's not we do, they do same back by thanking us and by following what we ask them to do. So, I don't know.
Thank
I
you
hope
so
that
much.
answered it.
Thank you so much. I think we have 2 more questions, but I would just like everyone to think that we're under 5 minutes now. We're at 4 minutes.
And we have one
So-
more on Zoom.
Yeah. One more, oh, sorry.
Okay. You ready?
Zoom?
We use telehealth for rural patients.
How do we use telehealth for rural patients? I think.
Can we use
Can we use? Well, I think Dr. Tung
Right.
she covered it. So let's give an opportunity to our on-site audience. Please.
I just have a quick question for the nursing side. Several of those 2 stories that were told, those patients went to nurses and said, I need help, something's wrong, and the nurses were brushing them off. So I know we have quite a few nurses that are attending virtually today. What advice would you give to the inpatient nurses that are seeing these patients for women or women of color or transgender women in the hospital setting that are reporting symptoms to nurses? What advice can you give to them?
I'll just start because I think it really does help to have some self-reflection. Many of the ways we perceive people around us, whether it's our family members, our community members, or our patients, has to do with our own lived experiences and how we were treated. And so it may well be that those same nurses have been brushed off themselves by the physicians they work with or their leaders. And I think having conversations within teams about how we're going to deal with these patients and how we are going to listen to patients and what are the, even being very concrete, because the more concrete and process you can do. So what are the red flag signs that we would always respond to and evaluate? And yes, you will have some patients, male and female, who will turn out to have nothing but anxiety. But if you evaluate those red flag symptoms in whatever condition that we are, we're always going to check a troponin if somebody is having X group of symptoms, as opposed to listening to them and saying, well, yeah, that sounds like the symptoms, but she's only 28, so it can't be heart. I think the more we can talk about how our own behaviors and our own experiences may be affecting the care that we deliver, and affirming that all of us want to give the best care. Blaming and shaming is not the way to go, is talking about how we can aspire to be our best for our patients. And nursing is really good at that, responding to that in my experience. And then setting up as many processes and things and checklists about what are the things we're always going to investigate, what are the things we're always going to do X or give this drug, can help a lot, because then everybody sort of starts thinking, okay, she doesn't look the part. I can't tell that she looks that bad, but I've got to listen to her, and these are the things we do when those symptoms are reported. So I think taking it away from the emotions and thinking about how we can aspire to provide better care, make better decisions, and let some of those arbitrary decisions about how we listen to people and how we treat them less arbitrary.
I think we had one short question, but we're 1 minute. You?
You're good. It's going to take more than a minute. I'll do it later.
Okay. Thanks, everyone, for being with us, both on site and virtual and on social media. And I'm giving back the mic to Dr. Bond.